can it be determined before birth if a child has a Chiari with syrinx or even a Chiari? And I guess that would maybe be in utero.
Repeat the question.
Can you basically determine before birth if a child has Chiari or syrinx? And I assume, you know, in utero, like looking for spinal cord defects, things like that.
Absolutely. So there are two ways to do that. First of all, with ultrasound, high-resolution ultrasound, and also with fetal MRI, you can determine not just presence of Chiari malformation, but also neural tube defects with reasonably good certainty.
I'm sorry, I apologize. At what stage do you do that?
Well, it depends on when you suspect a problem, but usually you can start around 3 months of gestation. You should have pretty good resolution.
It's not typically something we screen for unless there's some other type of, so I think the point is as Dr. Assadi said, we can see it, we can determine it, but it's not something we particularly, that you screen for. Chiari, I would say, and I would defer to my pediatric colleagues, but in utero at birth and even in, unless it's very, very severe, and there's, again, we saw yesterday, there's different types of Chiari, and so for Chiari 1, something we really wouldn't screen for the more severe congenital types. If there's a history, if there's other risk factors, I think that's where we would screen.
Yeah, we look at a lot of these prenatal MRIs now, you know, with these visits we have with these families with ventriculomegaly, or, you know, the one last week was even tough. It looked like a Chiari 2, you know, but we didn't see any spina bifida. You know, these get complicated in these fetal MRIs. They're getting so good, but we don't have a lot to say in terms of how we counsel the mom, you know, and this is usually pretty late in the pregnancy, well after the chance to, say, terminate for spina bifida if there's an interest in that. But we are seeing a lot more of these fetal MRs to try to interpret. Definitely can pick up the Chiaris.
Okay. And here's one I think that will be good for Mitra. Please explain what's happening in the brain when a child's able to run and play, but the second they stop, they're experiencing a horrible headache paired with severe behavioral difficulties.
All right, so basically the nature of problems in Chiari malformation, as was explained by my other colleagues, is mechanical, right? So we're talking about a space limitation, and we are talking about alterations in the fluid dynamics. And therefore, a great deal of symptoms are dynamic in these individuals and are manifested with changes in motor coordination and obviously headaches, and exertional aspects of these symptoms are pretty clear. So physical exertion can alter the fluid dynamics, and I think my colleagues did a great job showing to you and confirming how complicated these fluid dynamics are. So I think it's not too hard to imagine how exertion can alter that. And obviously, it can lead to headaches, it can lead to motor difficulties, and you know, I think the behavioral aspects of it is harder to explain, but for a child who doesn't have a frame of reference, when they're experiencing headaches and they can't get their act together, I think it's not unusual for them to feel, to manifest it behaviorally when they cannot express it too well. I hope that answers the question.
Question for you, Dr. Greenburg. How long after the surgery do you send out the post-op questionnaires? 3 months, 6 months, year?
So in this case, we sent out the questionnaires at least 6 months after surgery because we didn't want to send it out, you know, just a few weeks and not really have longer-term outcomes. But in some patients, it was a lot longer, maybe up to 10 years, with the average being about 4.5 years after surgery. Ideally, you'd like to be capturing everyone at the same exact time point, say 2 years, 3 years, and you know, down the line, we hope to have that type of uniform information. But in order to get enough patients to be able to say something meaningful, we did capture patients who are at these different time points, at least 6 months, but some maybe 10 years after surgery.
Okay. This is for
Dr. A quick follow-up to that. And as the same patient, do they get more than one questionnaire over time? No.
Yeah. This is for Dr. Grant, but I think we can open this to anyone. Can you speak more about what can be done for patients with Chiari with significant cognition problems, with anxiety, processing, attention, word-finding deficits, as far as pharmacotherapy or other alternate methods? I think we can open that to anyone. And if any of our faculty in the audience want to chime in, please do so.
So, I think I can pitch in. In terms of cognitive difficulties, obviously, when the nature of the problem is mechanical, in terms of chemical interventions, there's very little we can do to improve matters. So if they need a surgical intervention in order to reverse the issues with pressure, obviously that's what needs to be done. But in general speaking, we can always use stimulant medications, which can improve cognitive agility, attention span, processing speed, etc., with great results. So that can be offered if necessary.
Great. Here's an interesting question. Whole genome study, how much does it cost? And it goes on. Could it be done for $180,000? I don't know who. I think that's Dr. Keating back there is just trying to. That's right. That's right.
All right. Well, depends. If you give me the 180,000,
yeah, right,
I can
right.
manage that.
Yeah, you can give that to Dr. Assadi, care of. I think probably in a more broader sense, is it expensive? Is it something that most centers can't do?
Well, normally it's not something that you complete in one center. It's a multi-center study, and the one that I mentioned, for example, was NIH funded. So no, it's something that we're talking about a couple of $1 million to recruit about 100-some families, and the study that I mentioned recruited about 130 families, but you obviously need a larger size than that, and we're talking about a few $1 million.
It's another good general question. Is there a good place for all of us to access these studies and find out when they come out and new ones?
Yes, National Center for Bioinformation Technology, funded by NIH, check that, and has all of the current and published genome-wide associations.
And these studies should all be on the ASAP website with connections, correct?
I don't know.
And if it's not, it's John's fault. We'll get you that exact. John will do that too, because since he's a great guy, he's gonna. We'll get that so that you guys have it, so you don't have to be scrambling to write it down. But it's a great question. Let's see, you're popular here, Mitra. What genetic counseling might couples do if one parent's known to have a Chiari malformation or related issue? Basically, who do you recommend genetic counseling if one parent?
So generally, these families, these pregnancies should be considered high risk, and they go to a high risk clinic. The genetic counselors would take a pedigree and then would recommend the high resolution imaging studies for the fetus that we just discussed. And of course, from what I discussed earlier, you would remember that Chiari malformation is not a simple autosomal disorder. Therefore, in majority of cases, when the parents have it, the chances are the child would not have it. And if there is a malformation, and if it's detected early enough, of course, the parents can consider termination. But that's the best we can do right now.
There's a question, too, about the PowerPoint presentation, so we can get copies of...
They should be edited and on our website somewhere around that.
Yeah, they'll be on the website. You just have to edit them. Is there any evidence that the velocity of flow impacts blood pressure or symptoms of lightheadedness, dizziness? That's for Dr. Martin. Dr. Martin? And this really is for anybody. I mean, I think this is anyone, for the clinicians as well, as far as, I think it's more of a clinical, but anyone can chime in.
So from my view of it, there's a major problem with velocity measurements because they're acquired at one location, and as I showed, it's variable very quickly. If you just move slightly away from that location, they can be totally different. So I think right now there is not any studies that show, you know, correlation with specific symptoms and flow. But maybe in the future there would be some correlation if we had more details about the flow. Does that make sense?
Yep, absolutely, perfect. Is there, again, this I guess goes to Mitra, family clusters of Chiari, what type of genetic counseling do you recommend? And, you know, two parents.
Two parents being affected?
Two sisters, the person who's writing this has two sisters with Chiari Syringomyelia, as well as her. Her mother doesn't have it, her father's borderline. How likely is it that their children will have it as well? We need an exact percentage.
No pressure, right? I'm afraid I can't give an exact percentage, but definitely this may be one of those familial cluster cases that indeed there may be a gene effect with autosomal dominant pattern, and therefore the child, the fetus definitely has to go through high definition imaging studies. And of course the choice after that would depend on the parents.
Right. Another general question, if you'd like to participate in research studies, how can you get involved? I think wherever you're from, and there's everybody here is from literally from around the country, you know, talk to your center. You can, again, ASAP, one of our discussions this morning was doing clinical studies through ASAP, which we're going to start looking at doing. So there's lots of resources out there, but I would start with your medical center and ask your doctors. Because there's almost always some form of a study going on. And if there isn't, ask them. You know, ask them why they're not doing a study or a trial for Chiari and/or Syringomyelia.
If I may interject, there is also a website, genetest.org, that you can check, and pretty much you can find nationally or even internationally where they're able to check for a particular gene or where there is clinical trials.
Oh, that's great.
Genetest.org.
I'm just going to add, we have a study going now that we're collecting images for 60 Chiari patients per year for an indefinite period at the local hospital where we are. So if you want, you could email me, and this does not mean you would be included in the study, but I would have you on my email, and you know, it could be possible if you're the right age, and you know, we have to do gender, age matching, and all these things.
That's great. And how can they get?
Just my email is, I think it's.
We'll get it for you.
Yeah, it's, if you're really, you can ask me. My name is Bryn Martin. If you look me up, you can find my email.
Yeah. And I have a cell phone too. So, if adults have a change in CSF flow but no symptoms, should surgery be performed? No. Does dry eye syndrome have any relation to Chiari? I think there's some reports. It's usually in kind of bulbar symptoms when the syrinx gets high up into the brainstem, but there's none specifically as far as a syndrome that I'm aware of. I don't know if any of the other physicians. Genetics: 5-year-old post-decompression Chiari, paternal history of Chiari, hereditary spastic plegia. How strongly would you push genetic testing? I think I know the answer to that.
All right, so genetic testing is available for HSP, and that's available through multiple labs and is commercially available. So that part is not a problem. Genetic testing for Chiari is not commercially available for the reasons I just discussed, but HSP we can test.
You know, there's a question that you know, one of the great things about ASAP is you guys, this is a great venue for us. It's for us as well as physicians. We get to kind of have collisions of thoughts and ideas and be able to do things at this venue because it brings us together as well. And, you know, there's a question I get a lot from my patients who, and as you know, we refer a lot of patients for genetic testing, both adult and children. And a question I get all the time that stumps me is, what difference is it going to make, one? And that's easy because it's going to help us understand the disease and it gives us more information. But then it becomes a question of insurance, where patients get very worried because now they become a true diagnosis of a syndrome, a disorder, and they're very worried about their insurance, and that's a tough one for me to answer because I don't know. I don't know if you can or any of the other physicians can speak to that.
So based on the Obamacare, people cannot be discriminated against for having positive DNA testing.
It covers DNA testing as well? That's considered a pre-existing?
That's right. It covers testing. You cannot be discriminated against. However, there is no guarantee that you would not be discriminated against in terms of employment and in terms of life insurance. But in terms of getting coverage for testing, that's fine. And in terms of getting health coverage after that, you're fine. But employment and life insurance are still challenges.
Okay. All right, this is for our research colleagues. CSF flow in a child, what number should you be worried about? And again, we need an exact number.
So we don't know yet. Actually, the studies are too limited to say very much. And also, like I was talking about in my presentation, the variability between scanners and then even for the same person at the same scanner can be pretty significant. We need to establish what that actually is. And then once we know what that variability is, then if your velocity of your child at age 5 is like this, then we can compare statistically, okay, the average child age 5 at this location is like that. And kind of like when you measure the head of your child, I have children, and you know how they have their percentile distributions and where you fall on that? I mean, we need to get that kind of quantitative information, and we don't have it right now.
I can talk about that a little bit. Dr. Iskandar and Victor Houghton at the University of Wisconsin have published a paper, which I worked on a little bit, where we looked at peak CSF velocities versus age. Now, children have higher CSF velocities, normal children, and symptomatic Chiari children do. So you have to know what the child's age is. Adults, normal adults, have a peak velocity on the order of about 20 millimeters a second. Anything over 30 is a little shaky. Symptomatic adults often have peak velocities of about 50 millimeters a second. Children, like I say, I'll say around 10 years old, their velocities can be much higher. I had one child who had a peak velocity of 260 millimeters a second. That's really high. If you have a child and you think with a Chiari malformation and you want to get a flow study done, axial flow study, have them set the VENC. I would recommend, like I said, I'm not a doctor, but I would recommend setting the VENC at least 100 millimeters a second, maybe 150. If it's lower than that, you're going to get an awful lot of aliasing, and so you don't know what the peak velocities are. But again, peak velocities, yeah, they're useful, but they're not the whole story. Like I say, people with bidirectional flow actually tend to have lower peak velocities and more severe symptoms than people with higher velocity. So you have to see, do I have jets? Do I have bidirectional flow? That seems to be a little bit more important than the actual peak velocity. So like I said, you'd want to look at the paper by Dr. Iskandar and Houghton, get an idea of what a normal velocity is for a child. Like I say, it depends on age. Around 12, 13 years old, like I say, things level out, and something around 25 to 20 millimeters a second would be normal. Anything higher, anything above 30 or 40 is getting to be a little bit shaky.
And it's important to understand, these are all guides that help us. It's the whole picture. It's not just a one number or CSF flow or how much descent the cerebellum. It's the whole constellation. It really starts with clinical symptoms. So all these things just help guide us. Great question. Can you speak more about what DTI or diffusion tensor imaging is and what it may be useful for, and how can a person with a Chiari get involved in helping in research? So DTI is basically a way that we can look at the brain fibers. So for example, one of the things that we do now, which is considered cutting edge, which is really archaic if you think about it, we do brain surgery on awake patients. So if someone has a brain tumor or a vascular malformation in their brain, it's in a very dangerous area. There's two ways to do it. One, you can rely on physiologic monitoring, where we hook you up to wires, and there's a neurophysiologic technologist and doctor in the back of the OR telling us brainwave activity. It's not always that reliable. The patient's awake, and you're operating in a certain area of the brain, if it's near the speech, you have them talk, you have them read slides, you have them do, there's no nerve endings in the brain, so it's actually painless. It's the incision we make. DTI, or diffusion tensor imaging, shows us all these pathways and fibers. So we can, actually what it's helping us do now is not do the awake craniotomies as much, and we can see all these important pathways and navigate around them. We're just starting to look at this with concussion. We're starting to look at this with Alzheimer's disease because it's opened up a whole new door of allowing us to look inside the brain. So I don't know if any other centers are doing any research. We are. The problem with it is insurance obviously is not going to pay for it, and some of the sequences are more expensive. We have some funding, and we've cut out certain areas where we can look at this, and we're doing it heavy with concussion now. So
I just want to mention we have an ongoing study I'm a co-PI for, in which we're collecting DTI and fMRI and then CSF flow and also magnitude T1 and T2 images in Chiari patients. And overall, it's right. One important thing about the DTI is generally when you collect it for the whole brain, as they showed in this study, it's not very high resolution. In particular, in Chiari, the size of the spinal cord and the medulla and the cerebellum, where you're most interested, where the brain is probably being compressed, it's very small. It's only 10 centimeters, and the voxel size standard for most DTI is around 2 centimeters. So you don't really get a lot of information. What we're doing in this study is we're working with a special team that does reduced field of view DTI, so you get a lot higher voxel resolution down to about 0.5 millimeter resolution. And they've done this for spinal cord injury in the upper cervical spine and the medulla. So we're hoping from this study we're going to get some information to connect actually what they're talking about in that talk is connecting some of these cognitive dysfunctions with the underlying actual fiber tract alterations that might be occurring, and then also see if maybe there's a simpler way. I mean, maybe we can just collect magnitude images and those would be just as indicative, or maybe there's a measurement based on the magnitude image that could help us describe these other alterations that can happen, you know, like these cognitive deficits.
The software, I'll tell you, is getting a lot better, and it's amazing. We're using this now. Arlen Mintz, who's with us as our tumor neurosurgeon, he did, when he was at Pitt, did one of the first cases. We're actually using it in the OR now. Before, this was a research tool, and the software has gotten much, much better. So the posterior fossa is a little bit more tricky, but it's definitely a tool. So if you're near Ohio, touch base with that website. We're doing some work at Capitol Health as well. And again, check with your center and specifically ask for that.
Just quickly, we do quite a bit of DTI. You know, it's really incorporated now into your baseline MRI scans, and it's what you do with the data that gets interesting. You know, there's this post-processing that happens that takes a really dedicated team that's interested in this. The problem is if you don't have baseline imaging before you had surgery, say, it's less useful, right? If you've had surgery, now it's really hard to interpret because you want longitudinal changes. The other issue is across centers. You know, it's very hard to compare an Akron scan with a Stanford scan. You know, there's differences on these scanners, GE scanner, Philips scanner, Siemens scanners. You can't compare notes very easily. So we really need better coordinating efforts, you know, between these sites to be able to look at this kind of thing in a sum.
If you want to see something totally amazing and futuristic, there's a method called connectome mapping. And what this is DTI mapping superimposed with automated segmentation of about 1,000 regions of the brain. And it gives you kind of like a fingerprint of how the fibers are connecting to the different regions and how much connectivity there is. And I'm sure they've probably heard of this. It's really quite a big advancement. But if you look up connectome mapping, you'll see these amazing pictures of how the brain is being mapped now. And for sure, I think some of these methods are going to hit Chiari and help us understand, you know, what's going on. Right now, I mean, we're sort of behind the actual technology, really. I mean, it's always that way, that if the physicists and these people are advancing it really far, and then we have to apply it. So.
Yeah, and again, it's all about collaboration. This is a direct collaboration with radiology, physics, to it, but it's definitely, I mean, I think it's definitely one of the things that's going to help us in the future. Here's an interesting, how can we remove the misleading label rare from Chiari and other conditions that are far more common than the literature says? Well, it's a numbers game in medicine. If you have it or your family has it, it doesn't seem rare. It almost doesn't matter. But if you look at the overall numbers and the percentage of patients, humans, it's considered rare. I don't know if anyone has any comments on that, but it's a numbers game. All right, we're gonna put myself. I'm actually gonna show. Just want to show a picture while we're on this. So we're trying to.
Does anyone know the percentage or the occurrence to be classified as a rare disorder by the NIH guidelines? Maybe Dr. Heiss knows. 1 in 20,000. So the study by Spear is something like 1 in 3,000, right? Yes. Or 1 in 1,000. It depends on the numbers you look there, right? So it wouldn't be rare by the NIH guideline. If it's 1 in 20,000, then.
Is it low-lying cerebellar tonsils? Is it? Yeah, it's. But it's a good question, and I think the whole idea of ASAP is exactly that: is to to educate and to make everyone aware, not just patients. Here's a question I think for anyone: what do we do with asymptomatic? So an 18-year-old who's asymptomatic, and as far as playing sports. Do you believe that playing sports or participating in sports puts a young asymptomatic athlete with Chiari and, I mean, if you're talking about Syringomyelia, they're two different things, at higher risk of being symptomatic? So basically someone you're following. And I think there's probably going to be different answers.
It's a great question. I mean, this is something we struggle with every day, and it's really worth pulling that kid out, of a sport that he loves. And he thrives and has been playing for years. When we pick up this Chiari, I think it depends. And we clearly have scenarios where something real minor, clearly in the adult literature, there's case reports, right, over and over of very minor trauma that has resulted in a neurologic deficit and the patient's found to have a Chiari. And we know that exists, but to apply that to a child or adolescent that really wants to play a sport, it's hard for me to provide them evidence to pull them out. So I would support it, but we have to have that conversation with them and make sure they know the symptoms of what to look for, and I still follow those patients. I don't just say, oh, good luck, But we need to keep track of them and keep them in our clinics and keep watching them. And I also re-image some of these kids that have very tight Chiaris because we don't know the incidence of a syrinx and other things, especially if they want to keep playing sports. But I'm not the advocate to say pull them out just because there's a Chiari there. I really try to promote their quality of life if we can, not knowing any difference in the evidence.
Right. Yeah.
What do you do?
It's exactly the same thing. Exactly the same. If somebody has a really, I mean, they're symptomatic in any way, shape, or form. Football with a syrinx, a little different, but verbatim, I think, because these are formative years in children's lives, and to pull them out and take them out of the activities that make them who they are or who they're going to be, I think is far worse than any risk. But it's all about education with the family as well. This is a picture, just I wanted to pull this up. So this is a form of what we can do with DTI. This is a real patient. These are real tracts in the brain that we can put, and this is a patient we took to the operating room, and we can transpose this on an image guidance system in the operating room to help. So things have, we've really gotten a lot farther with this, and there are some clinical correlations that we can do. And you can see all those little things just look like a bunch of squigglies, but without that, you're just guessing. And everyone's brain is different. There's swelling, there's edema, they get pushed aside. So I just wanted to show the audience, this is what this looks like. This is what we're talking about. You hear all these names and things, but this is what it actually looks like. Okay, so what's Diamox and how does it help with sleep apnea?
Yeah. Glad you're paying attention for that. That was just a test question. I have no idea. No. It was, the Diamox we use, say, in pseudotumor, it's thought to decrease the production of spinal fluid. But in the sleep literature, that's not what they're after. There is a clear mechanism of Diamox on the chemoreceptors that when you're apneic, your CO2 goes up, your carbon dioxide, and the higher it gets, it'll eventually, supposedly, trigger your ability to breathe. And if that's not intact in some way, you're going to be apneic and not have this propensity, okay, let's breathe now because my CO2 is rising. That feedback loop is altered, in a patient with sleep apnea. And Diamox specifically will help that patient, at least in the literature, but it's all in the sleep literature. And actually, reviewing for this talk is the first time I really saw that, because we use Diamox routinely, in a patient with Chiari, pseudotumor. It's something that is well known, for decreasing the CSF production, decreasing percentage of the pressures is the theory, behind it that may help someone with a Chiari. But the mechanisms are probably twofold for sleep apnea, and I think what's been ignored in the sleep literature, many of them have Chiari, and the Diamox may also be affecting the CSF pressures, which is not in their literature. So, again, a chance that these fields can come together.
And to this sleep apnea again, can Cpap machine for sleep apnea be beneficial for someone with Chiari?
Well, definitely. I mean, these patients are...
If you're having, obviously, if you're not having any...
often these patients have sleep studies, and you've really documented what's happening, in repeated sleep studies over time.
So we actually just finished a study, it's under submission and publication, where we had healthy people have a Cpap machine put on them in the MRI, and then we removed the machine, and we did actually measurement of cerebral blood flow and also CSF flow at the foramen magnum and in the mid-sagittal slice, and we saw actually that the CSF flow is impacted from the Cpap. It was not mediated from carbon dioxide alterations. And basically what happened is the CSF pulsation to the spine got smaller when this machine was put on in healthy people who were awake. So this is not people who need, I'm just saying, so there is some physiologic impact that a machine like that, putting pressure on your lungs, can have on CSF. And that is probably something like stiffening the epidural venous plexus around the spinal cord, and because of that, the CSF pulse going down the spine became a little smaller, actually about 50% smaller.
Okay. I'm gonna, there's a couple that I'm gonna fire through these, and I'm gonna kind of give my answers, and then anybody, if they want to add something as far as the faculty, just so we can get to the next speaker, and I want to get all the questions answered. Is there a correlation between Chiari-1 and inner ear malformation fistulas? There's a correlation with tinnitus, ringing in the ear, even hearing loss, but as far as fistulas, no. I don't know if anyone else would disagree. Is there any continuing involvement of the VA hospital or engaging in syringomyelia or Chiari? None that I'm aware of. I don't know if Dr. Heiss, are you aware of any? Is there any active NIH going on with any of the VAs? The VAs have their own set of problems right now.
The VA they have a grant mechanism, and Congress has always been very interested in veterans. And I remember it was Senator Pepper years back. Someone from ASAP went to Dr. Pepper. She was Ann Charnley. She was a lobbyist and ASAP member. She had Chiari. And she went to Senator Pepper, and she said, well, we need a Syringomyelia consensus conference. And he said, well, I don't see what that has to do with what I'm doing. And he said, well, veterans can get it too because they can be injured in wars. He said, well, yeah, we should put this conference on. And that's why there was a Syringomyelia conference. So, yes, there has been money directed toward veterans who have post-traumatic syringomyelia. And the other message is the way to get government money is to put pressure on your congressman. So.
Yeah, good point. And then we're going to get the last question. Is there a correlation between brachial plexus nerve root avulsion and syringomyelia? A nerve root avulsion is usually traumatic in some way, shape, or form. So if you have a syrinx as well, it probably is related to the syrinx itself. An avulsion in of itself, no, but the trauma that would cause. So thank you, panelists.